Welcome to a video on basic wrist plaster-cast application. I'm Dr. Jaden Murphy, an emergency registrar. This video will outline the aims, learning objectives, disclaimers, introduction to casting application in emergency, step-by-step of casting application, acknowledgements, and references. The aim of this video is to outline and demonstrate basic wrist Plaster-of-paris or POP application. The learning objectives include listing the materials of Plaster-of-paris cast application, demonstration of the application of wrist Plaster-of-paris casting, description of the key steps in application of patient comfort and safety of plaster casts, and understanding the basics of cast molding. This is a reminder that this video does not cover fracture reduction or relocation, and this is only a basic introduction video, and also other forms of plaster application do exist. Fractures are one of the most common presentations within the emergency department. Of these, forearm fractures, particularly wrist or distal radial fractures, are the most common. It is because of this that fracture management and plaster cast application are an important skill for emergency clinicians. Plastering within the emergency department will commonly involve a substance called plaster-of-paris, or POP. This is due to its ease of use, availability, and cost effectiveness. Within Australia, this is the common brand used. The plaster will make up one of three layers of the cast itself. The first layer is for skin protection and cushioning, commonly formed by soft band. The second layer is the plaster itself, which is for fracture and mobilization. The third layer is the bandage, which is for the cast protection and holds it all together. Within the emergency department, you'll commonly see the use of back slabs. This is where the plaster only covers part of the fractured limb. This allows a mobilization, but also room for swelling of the acute injury. We will now go through the key steps involved in application of plaster casts, right from the inspection of the limb and choice of casting, through to the material involved, the steps of applying the cast, as well as moulding of the cast. The first step is to inspect the limb which is to be casted. You will be looking for any dirt or blood which should be cleaned, any cuts or grazes which need to be attended to, cleaned or dressed, and rings which should be removed. Remember, plaster casts usually stay on for about 2 weeks. When considering the position of the cast in relation to the fracture, it is important to consider both the mechanism of injury as well as the angulation of the fractured segment. Let's take the college fracture for example, one of the most common wrist fractures seen within the emergency department. In this injury, the fractured segment of the distal radius is angulated dorsally, meaning that the cast should be placed along the dorsal aspect. This both pushes the fracture back down to the volar aspect in the correct position, and also doesn't allow the fracture to slip back dorsally out of position. Conversely, in a Smith's fracture, the distal radius is angulated to the volar aspect. This means that the cast will be placed along the volar aspect, both pushing the fractured segment back into the dorsal position, correcting the fracture, but also disallows it from slipping back out of place. However, you will commonly see most wrist back slabs covering both the dorsal and volar aspect of the wrist, particularly the distal radius. However, it is important to consider whether the ulna is involved within the injury. When gathering the material for your cast, you will need the 3 layers, including the soft band, plaster of Paris, and bandage. You will also need scissors, tape, an optional stockinette or tubiform. At this point, I usually cut the tape into 3 5 to 10 centimeter segments, and of course, fill a bucket full of room temperature water. When measuring out a cast for a wrist, it is important to keep it 2 to 3 fingers distal to the elbow joint and just proximal to the metacarpal phalange joint, or MCPJ. This allows flexion of both the elbow and fingers. Soft band is a great way to measure out the length of your cast. It is easily ripped and then can be used as a stencil for the cutting of your plaster of Paris later on. Firstly, you need to count the amount of layers you need of plaster-Paris, which is usually 8 to 10, and each stack has 5 layers. Using the pre-measured soft band to measure out the length of plaster-Paris required, you then fold it in half, making a layer of 10, and cut to length. Measured against the already cut soft band, this will give you the length and thickness for the plaster-of-Paris required for the cast. Folding the plaster-of-Paris in half long ways, you then cut a triangle-shaped wedge along the inside edge about 1 centimeter from the end. Unfolding this gives you a diamond-shaped wedge which acts as a thumb space for the patient. An optional layer is to add something called a stockinette. This allows an extra layer of skin protection for the patient, as well as mild compression. When doing this, it is important to add extra length than the originally measured cast. This allows for tidying up of the cast later on, as you will see. Soft band is the first layer of the cast. It allows skin protection and cushioning. It's important to double wrap the first part for anchoring, and then allowing for the thumb. When continuing to wrap the rest of the forearm and wrist, it's important to overlap 1/2 of the width of the soft band. It is important also to ensure no skin is on show and the soft band is neat, tidy and tight. The ends of the soft band should be double layered to allow for fraying. Poor soft band application is a patient safety issue. Bunching up of soft band can cause pressure areas and potentially circulation issues. Areas where skin is on show between soft band will allow direct contact between the plaster of Paris and the skin. This can cause skin reactions and irritation. It is important to check your soft band application before applying the cast, as most plaster casts remain on for 2 weeks. Good soft band application is neat, tidy, firm, but not too tight. Before continuing, it is important to ensure everything is within reach of the patient, as once the cast is wet, time is of the essence. Wet the plaster of Paris by submerging the entire product underwater in a bucket, ensuring the whole thing is wet. Wringing out any excess water is important to ensure the cast isn't too heavy or too wet. And then, straightening out the cast, ensure there's no wrinkles or folds before applying it to the patient. Apply the cast carefully onto the soft band over the thumb. Any excess cast can be folded back and cut later. Ensure that there's an adequate length for the fingers and thumb, and when smoothing it out, do not dent it with your fingers or thumbs. While the cast is wet, the excess cast can be simply cut off. When bandaging, just like soft band, ensure to double layer the first bit to anchor. Then wrap the bandage around the cast firmly and tightly to ensure the cast stays in place. Again, just like soft band, ensure when bandaging, half the width of the bandage crosses the next half. This keeps it tight and neat. We then move on to taping. When taping, use the tape to pull the bandage tight. This keeps everything in place. Molding describes the process of putting pressure on the cast to ensure it's tight fitting and also in the right position for the fracture you are treating. This is done through putting pressure on the cast with the palm of your hands, ensuring the fingers and thumbs do not cause divots, which then cause pressure sores, and then manipulation of the cast to ensure it's in the right position. When treating wrist fractures, the position of the wrist and the cast is very important. This describes wrist flexion, extension, as well as deviation. When determining the position of the wrist post-casting for treating fractures, it is important to consider the fracture and the anatomy involved, in particular the radius, ulnar, and radial carpal joints, including the scaphoid and lunate. For this discussion, we will be focusing on the distal radial fractures, which are by far the most common wrist fractures. Wrist position can either be neutral, flexion, or extension. This is determined by the angulation of the fracture. Take this Colles fracture for example. The injury has caused dorsal angulation of the distal radial fragment. Following reduction, the fragment is pulled to the volar aspect. This reduces the angle between the fragment and the radial shaft. In order to maintain this position, wrist flexion is employed. This is the opposite to the mechanism of injury. Conversely, looking at this Smith's fracture, the injury has caused volar angulation of the distal radial fragment. Reduction will pull this fragment to the dorsal aspect, shortening the angle between the shaft and the fragment. This angle is maintained through wrist extension, again opposite to the injury mechanism. We will now talk about wrist deviation. This can either be neutral, ulnar deviation, or radial deviation. This is determined by the carpal radial or carpal ulnar joints. Today we will only focus on the ulnar deviation, as it is far more common. Deviation is usually required when there is impaction or shortening of a fracture. Take this fracture for example, where we have compaction of the distal radius. In this injury, forces have come down on the distal radius, compacting and shortening it. It has also decreased joint space between the distal radius and carpal bones. In order to overcome this, we must attempt to lengthen the distal radius and increase the radial carpal joint space. To achieve this, we will deviate the wrist away from the radius, or ulnar deviation. Now let's test our knowledge on moulding and wrist positioning. Take a look at this fracture. Think about the best position post-casting for this injury. For this injury, the best positioning would be wrist flexion and ulnar deviation. This is to overcome the shortening of the radius as well as the dorsal angulation. It is now time to tidy up the cast. If you fitted a stockinette, you can fold it back and tape it down. This will tidy up the ends and prevent them from fraying. It is now time to inspect the cast. It should be warm and hard as the plaster has now begun to set. Ensure the cast is in a good position for the patient, checking the patient's comfort and making sure there is good movement of the joints above and below the cast, whilst complete immobilization of the joint in question, in this case the wrist. Next, it is important to ensure there is good capillary refill and sensation of the fingers. Post-cast x-rays are important. Following reduction, it allows assessment of the alignment and positioning of the fracture, but also it allows follow-up clinics such as fracture clinics to assess the cast itself, the alignment of the fracture, and also if they need to be called early for recasting. Now let's recap the key steps involved in plaster-cast application. Firstly, we inspect the limb, making sure there's no cuts, grazes, dirt, or jewellery which needs to be removed. We then choose the cast type and position based on the fracture. We gather the materials required. We measure out the length of the cast required for the limb. We then cut the cast and make any alterations such as thumb holes which may be required. We then wrap the limb up in soft band and optionally stockinette as well, making sure there's no gaps or bunching of the soft band. We then wet the plaster-of-paris and apply carefully to the limb. We bandage and tape around the plaster-of-paris, holding it all together. We then mould the limb, ensuring adequate position, including any flexion, extension, or deviation which may be required for the fracture. We then check the cast, ensuring patient comfort, immobilization of the fracture, as well as adequate movement of the joints above and below the cast. We then repeat the X-ray, ensuring adequate alignment of the fracture and correct positioning. You now understand the key steps and processes involved in plaster cast application, particularly in the wrist. You can now confidently go forward and treat your patients. However, if you have any questions, there is always someone around to ask, such as the orthopedic team, the plaster technicians, the emergency registrar, the emergency physician, and nurse practitioners. They are always willing to help. I'd like to thank Hannah Thomas for volunteering as a patient model, Dr. James Tang for assistance, and Gladstone Hospital for providing a space to film this video. I acknowledge and reference any non-original material involved in making this video.